So friends, hello. As you can see what is here, okay, is this huge region of lateral pelvic wall fibrosis. Okay, now of course we are going to be doing a ureteric reimplantation on this. I mean, it's a no-brainer. Okay, it's a no-brainer. I'm just telling this to you because we have already demonstrated a part of the ureter, how bad the ureter is on our WhatsApp groups. But you know what is really important for everyone to understand is this, that you cannot be leaving this tissue behind, okay, removing the ovaries and then thinking that everything will heal off. Okay, simply it does not happen. It's simply there is a tear there in the external iliac. Okay, see that the external iliac has just undergone a tear. So basically we require proline, maybe 20, no, not 20, 40 proline should be good in order to manage the tear, or 40 Vicryl should be good. Okay, the primary thing which you should do in an external iliac venous injury is till the time they arrange. See what we are doing. Basically we are just, oh instrument bahar nikalo aapka. By the time people arrange anything, bahar nikal do and ye andar dalo, bipolar. So see, this is going to be so interesting today. Okay, एक सेकंड के लिए इसको पकड़ो, सुनो, इसको पकड़ो, इसको विजय, एक सेकंड इसको पकड़ो. So I am being assisted today by Vijay. He is a very nice boy, but he is a new boy in the OT. छोड़ दो बेटा इसको, छोड़ दो आप, बाहर निकालो. Thank you. Can you see that injury? Now, my bipolar, or rather Vijay's bipolar, has just gone and held on to that injury. बराबर? अभी आप इसको पकड़ लो बेटा. Thank you. So till the time everything else is getting arranged, okay, you can see that there is some amount of this thing, basically staining which has occurred on the camera. मैं ये पकड़ के रखता हूँ, आप कैमरा साफ कर लो please. So let the camera get cleaned up, let the proline come in. So the proline is got ready, very nice. Rupali has made the proline ready. Okay, itna, बस इतना सा कट कर लो. Now ideally good that somebody went and called Vismay, that Vismay has also come in. Vismay has also got ready for handling something like this. मुझे यहाँ पे नहीं, वापस साफ कर लो. It's a very bad case actually, because you know she's had previous 3 surgeries and you know laparotomy, laparoscopy, everything people have done pa. Suction दे दो. Fine. So once I have the suction coming in my hand, Vijay has done a great job. See, no much bleeding. Whatever the tear is, na friends, it is a tear on the external iliac. This is that ureter which we have just cut and which we have pushed back. I think this is the things you know one has to probably learn and probably understand as to how to manage in a circumstance, you know, where everything is getting arranged. So if you have taken home the first point, then the first point of managing this is basically not to panic. Okay, do not panic. It's okay. It can happen to everybody who is operating. So if by mistake you are somebody who is you know, who is doing surgeries, then all this is going to happen. What is it? There is it is a tear. You know, it is a straight tear which has happened. So nothing. Tear is going to happen. You can see the tissue above it. You can see that fibrotic tissue. You can't leave that fibrotic tissue behind, na. You have to manage that fibrotic tissue. See this. So that fibrotic tissue is now removed. So till the time everything is getting arranged one by one, 12 mm का port दे दो. Now see, the great thing is Vismay has come. Vismay has held on to everything. So in 1 minute's window, or in maybe 5 minutes window, from Vijay it has gone to Vismay. 12 mm will be given to us. 12 mm de do bhaiya. Why 12 mm? Because just in case I require any clips. All this is urine, huh? All this I am not worried. This is urine. See this? This is that open end of the ureter. See, this is the open end of the ureter where we are going to do a BOARI flap. So she has had a huge lateral pelvic wall infiltration there. This is the region where it is. So I just actually want to see the lesion one time more. Agada Vijay Vismay. Chhod de. Yeah, I can see it cleanly now. And Maushi suction karenge ek bari. Yeah, that is where Vismay has held it, and what Vismay has held is actually perfect. Okay, so it's a good hold over that tissue. Now it is no longer bleeding. What have I also done simultaneously? I have dissected the vein. See that? I have dissected the vein away from all the other margins. Huh? Very easy, very nice, very nice. See this? Vein is now dissected away from all the other margins, which is what, of course, all of us should be doing. Always dissect the vein away from all the other margins. That is what has to be achieved, which has been achieved. So there is no reason for anybody to worry. And now I will come in with a 12 millimeter, please. So my trocar, which is a 5 millimeter, is going to become a 12 millimeter trocar. By the time the trocar becomes 12 millimeter, vascular clip has come onto the trolley. So the vascular clip has been got ready. Once the 12 millimeter trocar has come in, see this is the 12 millimeter trocar coming in through the 12 millimeter trocar. Immediately will come in two non-tooths with the suture. And see guys, you got to do this with your fresh staff. This is a staff, I mean not every staff is going to be like super trained from the first day of your practice. So this has to be done by you in an environment like this with absolutely fresh staff. I mean, though nothing much has happened, I would be happy if the mic is given to Vikas sir, our chief anesthetist, who is in the operation theatre, because Vikas sir will also have his inputs as to what should be done ideally when it comes to managing these types of injuries from an anesthesia perspective. So see, first suture has rammed through the posterior window, and the second suture I am passing through the little anterior window of the injury. See that? Posterior window and anterior window, both I have taken through 4-0. This is 4-0 proline which has come inside. I can also use a clip, guys. So don't worry about all of that. I can use a clip. I have just taken this suture at this moment. I would just want to test. I will do a test bite for this so that I understand if everything. See, it is a fine suture, so you have to keep your field clear. Okay, and it is proline, so it will escape the tissues very fast. Chodo, Vismay chod. Chod de Vismay, halka hatti. Now Vismay has left. Chod de. And when Vismay leaves, see, most of the injury now is going to be sutured off. Correct? So I have judged that the injury is going to get sutured off. I am pretty happy. Okay. Yeah, great by Vismay. See, this is the advantage of getting Vismay immediately. He knows what to hold because he has seen so many vascular injuries, right? Sorry, Vikas sir. I wanted to give you time to speak on this. Please speak. Yeah. It's for you.
So if something like this happens, what we first do is we try and collect blood for grouping cross matching if it has not been done before. We take a bigger and a better IV access. So if it is a 20 number, we take an 18 or a 16 number. All this is in anticipation of a larger blood loss. Here everything is under control, but as an anesthetist I would also like to see, I would like to be prepared ahead and anticipate. It is not always that you can always control the blood loss so quickly and so effectively. And as Dr. Jay said, in the meantime he has organized all his help. Help is required, and so actually you should shout for help. Here Dr. Vismay has come. He's also arranged for vascular clamps.
Everything has got ready in 5 minutes.
Everything, yeah. So that is very important. And the dilemma with
Suction.
an anesthetist
Suction.
likely to face here is, under such circumstances, you increase the intravenous fluids to compensate for all this
बस बस बस.
low intravascular volume. But here you have to
छोड़ दे.
judge or make a balance between the urine pouring out of the cut ureter. So
Right.
that will impinge his vision, or that will blur the surgical field, and it will not help in the suturing of the vessels which is required. So that is another thing. But obviously hypotension takes precedence over all that. So if the patient is not maintaining vitals, then you give fluids, colloids or whatever is required till blood comes.
Correct. But see, often the first reaction, I think the first human reaction in a vascular injury is panic. Correct?
That's right, yeah.
So we have to learn that, or probably we must, I should not use the word learn, because I don't think,
It can be that well learnt, yeah.
I don't think it can be learnt, as sir mentioned. But what I think is important for all of us is to probably understand that it is manageable, right? You are operating, when you are operating such type of when you are operating such type of cases which are complicated cases, I think you have to get used to you have to also get used to handling this type of stuff in life,
Yeah.
is what I think,
Yes, and as a surgeon who does such types of cases, he or she should always be prepared or should anticipate. It may not happen, it may happen very rarely, but when it happens, one has
It
to
is not
anticipate
predictable. The problem of the
and has to be quick.
Yeah, the problem of these events is that, when you try to plan for this, it is not predictable in my opinion. This is my opinion about this.
That's right, yeah.
You can't predict that, okay, this case I will have a vascular injury. You can't sort of go in a situation thinking like that, is what I believe. And I think that belief is very important for all of us, okay? Because nobody wants a vascular injury. Nobody is the word. Because it is as Vikas sir beautifully mentioned, you can't predict what is going to happen in a vascular injury. So don't be in that sort of a legion where you start believing that, acha, I have repaired a vascular injury, so nothing happens, I can repair one more. Every vascular injury is different, and in the meanwhile I have not put a stent inside so far, and I have started operating to push the BOARI flap through this. See, remember guys, this is a see guys, this is a very tough case otherwise, because she has been operated so many times before. And as I told you, the minute you become even a slightly prominent unit, okay, you will only end up getting these types of cases. You will not get you may not get the routine cases which you think you should be getting. All that is not going to happen to you. So you have to sort of get very used to handling such type of stuff in life, okay? So now see this, the primary anchor bite, I will just tighten here a little, because this tightening is just going to help me by a little, and you will start seeing what's going to happen. I am taking a completely reverse biting for the BOARI flap in this case. You have multiple methods of taking a BOARI flap, as I have told you, and majority of the methods can be considered to be right. I am using Stratafix. We have our urologist here, Dr. Mehta, who actually who has stopped using Stratafix. He prefers, rather, I would not use the word likes, he prefers to use Vicryl, because he believes that in his hands he is able to get much more better this thing with Vicryl. But it is an independent opinion of Dr. Alap. I think I'm super happy using this. So see, I just use this, okay, 2 bites done. So one side of the BOARI is tightened, okay. Now when one side of the BOARI flap is tightened, you can simply underplay the suture. Okay, it is come nice and clean on one of the windows, so you can just get it out, because when you get it out, na, see, the space is less, the angles are less, huh? This is a very less space in whatever we are operating, na, right now. The space is incredibly less, plus you got to take full thickness bites at all times. So after a few bites, yeah, after a few bites, especially after the apical bite, that means especially after the bite is finished from the apex here, see, this is the place from where we have done the spatulation. So when a large spatulation has been made after this bite only, I normally like to now put a stent, because it gives such a great anchor here. You will just see this, see, the anchorage is so good, because you have such a large window from here. Can you see? This is such a large window which is available. तो अभी stent दे दो. Right. So let the stent come in. नहीं, बहुत बाहर निकल दिया अंदर. बस 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 बस. So here comes the stent inside. Now when the stent has come inside like this through one of these planes, you can see pushing the stent over a stable ureter is so much more easier. Actually I don't have the correct instrument which has been provided here, so I will switch to the bipolar. अंदर डाल दीजिए, थोड़ा अंदर पुश करेंगे गाइड वायर को. बस, thank you. So with the guide wire now coming in, it's easy to push it in from here laparoscopically, because the entire architecture inside is a stable architecture. If you see, though the port positions are such that it is difficult, believe me, it is difficult, because she has had previous 2 laparotomies, and she has had everything, basically whatever you can think of, na, she has had, and then she has come for her final surgery. So it is tough, but then fine. See, with this stabilization, na, when you push it in, see, it goes inside so beautifully. Out. Thank you. So that guide wire goes out, and see, with a stabilized window there now, isn't it, Vikas sir? It is easy with this stabilized window, isn't it? And it becomes very fast also. This is otherwise a very time consuming procedure, isn't it, to push that stent inside. So go full thickness, because that is the standard. It is the standard to take a full thickness bite, and you will see how beautifully the bite starts to flap now. See, from here. Okay. So the whole thing has come. It has formed a flap. It is a tension free flap, because that is what is very, very important for all of us. Alrighty, and now the final few stitches to keep the flap nice, clean and expanded. See, these adjustments which I am doing through my needle holders, correct, are very very fine adjustments. You must learn these adjustments the of the thing on a pelvic trainer, and hopefully it will help you. So here we go. So see this, the ureter has come on the flap, saw that? Now once the ureter comes on this flap, then life is really really easy, believe me guys. So do not stricture it off, take a thin bite here. This is enough, this bite, and everything is placed good. Now you can just seal it off. So how do you seal it off? So I have been taught by my urology teacher that the urothelium begins to heal itself within only 6 hours of you placing these stitches, and that is a great thing which you should try and take sort of an advantage of when it is healing so fast. You can't one more thing which is very important has been taught is that you can't really achieve water tightness in every bite. Okay, so you can't have a watertight bite all the time. You will have a good bite, but everything is not going to be like super watertight. So always keep a drain. Again, of course, these are not the things which we don't know of, but these are the things which we probably need to reflect and we probably need to understand. Simple. So I'm sure we are all going to be understanding all of this. So from here, we go full thickness. Just few more bites, following which the flap repair and reconstruction will finish, because it makes it an absolutely tension free repair. Full thickness. See this is the urothelium, full thickness. I would of course like to know, because as I know everybody is a super specialist in treating this, and I'm sure most of you have so many cases for handling this and voicing out your experiences, so that all the students can benefit and learn from your vast experience is going to be something which is important for all of us to know and learn and replicate if there is something better, because there is always going to be something better in somebody's technique which we can try and incorporate. So I'm about to finish maybe the last penultimate, maybe 3 bites or 4 bites using the Stratafix. I shall be very happy to note down your comments. We will be removing the specimen through the 12 mm port, and we will be putting in a drain inside, and then we will be coming out. Okay guys, so